Hi, and welcome to the COPD Management Guidelines and Office-Based Spirometry Interpretation. This is just going to be a brief review of the GOLD guidelines and some great tools put together by our pharmacy department with some best practices fact sheets that are going to help you navigate, hopefully, the world of COPD for your patients. So screening for COPD is very important. Oftentimes COPD is suspected, but based on symptoms, people can present in many different ways. Some people call it tired, some people call it fatigued. Less of 40% of patients are ever formally tested, even with a screening spirometry. It's surprising how easy and widely available it is, but people tend to have some clinical biases and just start to go down one pathway without really confirming the diagnosis. As you know, the symptoms of COPD are neither specific or very sensitive. Dyspnea can be everything from COPD to thyroid disease to heart failure to cardiopulmonary deconditioning, or even a bad back. So the symptoms are not diagnostic alone and require some additional objective testing. The importance of getting this objective testing is to help achieve some clinical stability, evaluate your treatment efficacy, and also it will predict morbidity and mortality. Basic spirometry is very easy to do, and many of our offices have it available in the primary care, some of the medical subspecialties such as allergy and pulmonary, and this goes back to everything we learned in medical school. These different lung compartments people start to lose touch with, so we're just going to walk through them quickly one by one and understand what information we can derive from a basic spirometry. As you know, with this maneuver, we take a deep breath in and we blow out as fast and hard as we can until we stop blowing or told by the machine by the N number of beeps. We need a minimum forced expiratory time, and that forced vital capacity is all the air they can fill their lungs with and blow it all out. That forced expiratory volume in 1 second is the majority of the volume in people who don't have underlying obstructive disease. Greater than 80% of your volume should come out in that first second of blowing. We look at that in that FEV1 to FVC ratio and how much of your total capacity is exhaled in the first second of the maneuver. And this is the break point, looking at whether or not they're obstructive to expiratory flow. The forced expiratory flow rate at 25 to 75 of expiration is the decrement in liters per second. If you will, this is now a wind speed. The less air we have to move, obviously, the harder it's going to get. And as we get down to those smaller airways that can start to collapse, we're going to see normal decrements in flow, but there's a particular pattern with obstructive pulmonary disease. Most people are pretty familiar with their peak expiratory flow rate. That's what we check down in urgent care when an asthmatic is coming in and what asthmatics are checking at home. It's a little less sensitive in someone with established COPD, but we still measure it. On your office spirometry, you're probably not going to be set up to give a bronchodilator such as a nebulized albuterol or 2 puffs of the patient's Ventolin, but if they do have Ventolin, you can go ahead and repeat this spirometric maneuver after the albuterol administration. Of course, this printout is going to come with some reference ranges, and those are specific to age, height, gender, and race. A 6-foot-tall white woman's lungs are going to be very different at 40 from herself, as well as when compared to an age-matched, let's say, 65-year-old Asian male. These are all derived from normative data sets, and most of our spirometric machines have the NHANES versus our equipment in the lab, which is GLI. We do need a forced expiratory time of 6 seconds. This is not an intrinsically innate maneuver for patients to do, so the person coaching them through spirometry has to have a lot of experience with the technique and get them to fully exhale for 6 seconds. If you've never done a spirometry, you'd be surprised how hard it is to actually prolong exhalation for a full 6 seconds. This is a real-life example from a patient of mine who came in with increasing dyspnea. We were determining if she was having an exacerbation of her asthma. You'll see in the first column, those are her best values. She had 3 successive trials. The last column would be the predicted values for her age, gender, height, and race, and then the patient's values of percent predicted. You see her forced vital capacity is 96% predicted. Of the 3 liters that she has to exhale, 2.38 of those liters, or 78%, come out in the first second of blowing. And then you look at her speeds, her forced expiratory flow rates at 25 to 75% of expiration. And she's able to sustain an expiratory time of at least 6 seconds. This now is another patient that was just seen this week to be evaluated for COPD. This is from our formal spirometry, so the platform's a little bit different, but again, the numbers are the same. FVC of 3.59 liters. You see that's reduced below the lower limit of normal for this patient. Of the 3.59 liters that he has to move, only 1.6 liters, or 45%, comes out in the first second of blowing. So this is obstructive pulmonary disease. He is obstructed to expiratory airflow. Now, when you have a large airways obstruction, you're going to see that in the smaller airways. So his expiratory flow rate's at 25 to 75% of expiration, or 0.58 liters per second. These values do not significantly change after a bronchodilator. In the lab, we define a bronchodilator response as an increase in FVC or FEV1 of at least 15%. He does get some better values on subsequent efforts, but you see the degree of his obstruction is unchanged. If they have a normal FEV1 to FVC ratio and we just see a decrement in the small flow rates, like somebody with asthma, we need to see the FEF 2575 or the FEF 50 go up by at least 30% to consider them bronchodilator responsive. And this is a relevant assessment when you're looking at long-term pharmacotherapy. This is a patient who is having a basic spirometry in the office. You see here that their FVC is normal. Their FEV1 is also normal, but their ratio is a little bit reduced, not below 70%. But when they get their bronchodilator, their FEV1 goes up by 15%. And unlike our last example, this ratio also increases by 18%, as well as an increase in these late forced expiratory flow rates. And so this would be a finding more consistent with asthma compared to our other patient that had established COPD. These are your flow volume loops that are on your curve. And a normal flow volume loop, as I told you, if we get most of our air out in the first second of exhalation, we have decrements in flow rates as we get to the expiratory flow rate at 75% of the maneuver, 50% of the maneuver, and 25% of the maneuver. And this is the inspiratory limb. This is your board question here, people. This is a flow volume loop that is obstructive disease. This is the expiratory limb, and on exhalation, they blow out as fast and hard as they can, and you see this decrement in speed blowing out. So this scooping of the expiratory limb with a normal rounded inspiratory limb is an obstructive ventilatory defect. So we define an obstructive ventilatory defect by Gold criteria as an FEV1 to FVC ratio of less than 70%. There's a lot of criticism, but this is what's widely used across the literature and in clinical practice. A fixed obstruction is irreversible after administration of bronchodilator. And we need to also assess the absolute degrees of reduction in the FEV1 and FVC to further evaluate how severe their disease is. Any abnormalities on screening spirometry should prompt the patient to be referred for complete pulmonary function testing, where we get additional values of total lung capacity, residual volume, hyperinflation, gas trapping, and diffusion. So when we get to the GOLD initiative, the Global Initiative for Chronic Obstructive Lung Disease issued its first consensus report now almost 2 decades ago. There are ongoing revisions, but these are the guidelines across the expert consensus panel together with the most contemporary literature that's going to drive our management of COPD. Here, these patients are classified by the severity of the reduction in their FEV1 from stages 1 through 4. This is completely based on FEV1 and not FVC. Mild obstruction, or I should correct myself, mild COPD is when the FEV1 is preserved greater than 80% predicted. Moderate is when FEV1 is between 50 and 80. Severe is when the FEV1 is between 30 and 50, and very severe when their FEV1 is below 30%. And the FEV1% predicted is proportionate to their morbidity and mortality. Groups A through D are based on their functional respiratory impairment, as well as their history of exacerbations. It is the group rather than stage that really helps you understand which pharmacotherapy you're going to pursue. So our team has put together the best practices in a 2-page flow sheet that can be found under the Best Practices tab on the intranet. You want to understand who you're going to screen. Common signs and symptoms of COPD are dyspnea, cough, sputum production. We look at the risk factors, obviously, such as any family history, tobacco smoke, and exposures. The severity, as we outlined by the GOLD criteria of stage 1 through 4, mild, moderate, severe, and very severe, which is predictive of mortality. And then we look at their functional impairment. The Modified Medical Research Council is very similar to the New York Heart Association classifications. Grade 1 is when they're doing more than level walking, if they go up a hill or if they're walking fast on the level. Grade 2 is they walk slower than people of the same age with a greater level of breathlessness or needing to stop. Grade 3 is the person that can't make it across the room, and grade 4 are the people that are really having rest symptoms or symptoms with all of their ADLs. The other is the CAT test, looking at how many daily symptoms they have from their COPD, including cough and mucus and tightness, together with their functional impairment. You can use one or both of these when you're going through your group classifications of A through D. You do want to add this to your clinical documentation because, as we reviewed at the group meeting, correctly documenting and classifying the degree and severity of illness is going to predict which group our patients fall into as we get into increasingly complex risk stratified contracts. If you correctly classify their COPD, they're going to be appropriately defined as higher risk and therefore getting attributed to all the work and the complex care that you're doing. For everybody, we talk about non-pharmacologic therapy. We want to assess their smoking status, their adult respiratory specific immunizations such as influenza and pneumococcal disease. For patients who have marked limitations in their functional status, we talk about pulmonary rehabilitation, which in the National Emphysema Treatment Trial was the only modality associated with an improved survival. Many of the other pharmacotherapies can stabilize FEV1 and reduce frequencies of hospitalizations and exacerbations, but physical therapy in a formal certified pulmonary rehabilitation program was improved lifespan. They lived longer. We can talk about oxygen therapy for people who have resting hypoxemia or a saturation of less than 88% at rest. But in October of 2017, we had the first randomized controlled trial of supplemental oxygen use with people who do not have resting hypoxemia, and it does not prolong life, and it does not improve their respiratory specific quality of life. So only patients with resting hypoxemia do we need to start to consider this. We have to talk about appropriate cancer screening, such as low-dose cancer screening in persons who are 55 to 80, a 30-pack year smoker, have quit smoking within the last 15 years, or are currently smoking. We want to monitor their symptoms and follow-up, and we're going to keep moving forward towards pharmacotherapy. So pharmacotherapy has become an alphabet soup. These are classes of treatments: short-acting beta agonist, short-acting muscarinic antagonist, long-acting beta agonist, long-acting muscarinic antagonist, and inhaled corticosteroids. Each class has indications based on the stage, severity, and groups, including frequency. How these classes of medications are delivered are now in a metered-dose inhaler, a soft mist inhaler, a dried powder inhaler, or a nebulizer. Based on your patient's flow limitations, they might not have enough force to inhale a dry powder inhalant. Based on your patient's other medical comorbidities, they might not have the hand strength and the coordination to be able to take a metered dose inhaler. Some of these drugs are going to be best delivered by nebulizer, and all classes are now available in multiple different forms. So we really want to individualize the delivery system based on your individual patient's degree of airflow impairment, their compliance with therapies once a day versus multiple dosing, and their comorbidities as well as their coordination and medical needs. So in the pharmacologic treatment algorithm, which is also at the best practices page, based on their group A, group B, and again, this is people group A, minimal daily symptoms, minimal functional limitations. They have no exacerbation history requiring hospitalization. They can have a short-acting beta agonist as needed and evaluate how often they're using that. If they're using the short-acting beta agonist daily or even more than 3 times per week, maybe you want to increase therapy up to a daily long-acting bronchodilator. We can continue, stop, or try. Group B are people with more functional impairments, but they don't have a history of hospitalization or frequent exacerbations. Long-acting muscarinic antagonist, the most common one out there on the market is Spiriva. The newer classes are in a dry powder inhaler, and these were associated with stabilization in FEV1 as well as fewer exacerbations and improved respiratory specific quality of life as assessed by their respiratory symptom evaluation. If there are persistent symptoms, we want to step up to dual long-acting bronchodilator therapy, combining a long-acting muscarinic antagonist with a long-acting beta agonist, and you can follow the algorithm through Group C and Group D. Certainly anybody who has severe daily symptoms with frequent exacerbations or hospitalizations should be referred over to the pulmonary department. So in the pharmacotherapy appendix, our pharmacy team has done a beautiful job of outlining all the different inhalers, the generic names, the brand names, the modalities which they're delivered, and this is across all of the classes. So please go to this resource when you're looking at starting a muscarinic antagonist, and most of these are on formulary. The hard part is for nebulized therapies in Medicare. Medicare Part B as in boy, not D as in dog, is what pays for nebulized home therapies for patients with COPD. So classifying and writing that documentation is very important for the patient to get that pharmacy benefit. I know this was a quick review, but it was designed to be so. Please reach out to the pulmonary department with any questions or concerns, and I hope you found this helpful today.